A continuación, la doctora Linda DeCherrie, vicepresidente de Estrategia Clínica e Implementación en Medical and Home, es directora de clínica del Mount Sinai and Home y profesora de Geriatría y Medicina Paliativa del Icahn School of Medicine del Mount Sinai. 20 años de experiencia liderando procesos de atención domiciliaria en Estados Unidos. Doctora Linda, por favor, este es su escenario.
Thank you so much. Thank you for inviting me. Put that over there. Perfect. And I'm sorry again, you have one more talk in English, and hopefully you can use the Interprify to understand. So yes, I'm Linda DeCherrie. I'm the Vice President of Clinical Strategy and Care Delivery at Dispatch Health, along where Pippa works as well. I am also a professor at Mount Sinai School of Medicine in New York City. There's my disclosure. So my talk today is on scale. And I'm going to talk a little bit about my past experience in understanding what is needed for scale. If we have this great model here of hospital at home, we want to be able to offer it to as many patients as possible. We know as a fact that it's better for patients if you pick the right ones to do this at home. They have better outcomes, less readmissions, less likely to go to nursing homes. And so therefore, why not want to offer it to as many patients as possible? Scale is also really important for the financial aspects of this. You can often start with a pilot, get a little bit of money to start something, but if you're going to really have an established program that's going to go on for years and years, you can't cost more than the money you bring in. You have to justify your operations, and that often requires scale, because 1 or 2 patients at a time is not going to do that. So I'm going to talk a little bit about my history and understanding that. So like Pippa, I started off in home-based primary care. At Mount Sinai in New York City, they have a program called the Mount Sinai Visiting Doctors. It was started in the mid-90s. And it was at that time the largest academic house call program in the country, where we went out, you had a backpack, we went on the subway, on the bus, or we walked to patients all over Manhattan because you can't find parking. And we brought all our medical students and all our internal medicine residents with us to go to the homes of these elderly homebound adults in the city. And it was a wonderful program. I joined about a decade after it started. And I almost instantly knew we could do much more. That as soon as my patient who had pneumonia got sick and needed oxygen, I couldn't call the oxygen company and get them to drop off oxygen in 1 hour. But this patient wasn't doing well. He couldn't stay there at home if it was going to take 4 hours. And so we would have to then bring them to the emergency room, right? And so that, if we just had a payment and a system of the logistics, I knew we could do this because I knew how to take care of the patient. I knew what antibiotic to prescribe, but we didn't have all of that set up. And so that's when I, like many others, then looked at the literature, understood how other countries were doing this, talked to Dr. Bruce Leff, who had started doing some hospital at home in the mid-90s. And in 2014, the US government announced some very large awards that you could apply for if you had something innovative and that was going to develop a new payment model. So we said, okay, let's try that. And so a group of us at Mount Sinai applied for a CMS award. It was for $9.6 million, so a pretty big award to try this out with a Medicare fee-for-service population. And Medicare, again, is the insurance for the elderly and some others in the United States that almost everyone gets after 65. So we got this nice award from them to really try this out and start a program. But then it was only 3 years. We also had to understand how to do this at scale to justify the ongoing program. In 2018, we kind of incorporated all the home-based programs under one umbrella. At that point, we had a home-based adult medicine program, home-based pediatric program. We had palliative medicine at home, and then now this hospital at home. And so we were starting to put all those together and thinking about the scale and dissemination. You'll see this thing where I say SIHA up there. Because when we started hospital at home, we only took patients from home or from the emergency room to do the entire hospitalization at home, day 1 through whatever. And then we took care of them for a couple days after as well. But we started right during the pandemic to help decant the hospital, take patients who were already a couple days in the hospital. Now that's very common. Now most programs do both right from the start, but at that time that wasn't as common. And as Pippa mentioned, during the pandemic, the US government said, okay, we'll pay for this the same as any other hospital. It is a virtual unit of your hospital that is taken care of at home, but you have all the same rules and regulations otherwise to take care of those patients at home. And what I loved was the implementing and scaling of these programs. And Mount Sinai was up and running and doing their thing. And I said, well, I want to help a lot of hospitals develop these programs. So that's when I left my full-time employment and moved over to Medically Home. And that has now been merged with another company. And now we're called Dispatch Health. So for scaling, I think the big questions you have to think about is going deep or going wide. And I would argue that you have to go deep, usually before you can go wide in thinking about this scale. And you really need to fully commit you're going to do this. And as I mentioned, this allows as many patients as possible and is key for your sustainability. So we developed Medically Home through literature review and our own experiences, 10 intake principles. And this is how you really are thinking about, because if you start off and you can take 1 or 2 patients from COPD, but there's been like 100 patients who are admitted with COPD that day, but you're only taking 1 or 2, why did you miss out on the other 98? Maybe a few went to the ICU, okay, you can't take those. Maybe a few others, but there's got to be at least 50 there that you could have tried to offer this program to. And why didn't you? And so this is where we work with our health systems in the implementation, like Pippa mentioned, to really think through these 10 intake principles. And the first, and it's why it's the roof of the house, is leadership. Leadership of the hospital. The CMO, the CEO, the president, they all need to say yes. If a patient comes in and they have CHF, they have COPD, they have pneumonia, home is the default. That's what we want to do at our health system. It is the best thing for the patient. And everybody has to align. That random cardiologist, the pulmonologist over there, they have to also understand this and want to be part of it. We also believe there should be triad leadership. This is interdisciplinary, multidisciplinary care. We usually recommend a physician, a nurse, and an administrator. There could be other triads, but something like that. This is not just a physician service. This is truly care that would be offered in a hospital. Usually when you're identifying and bringing in patients or admitting patients to a hospital, you don't need to think about who should go. Maybe you have a flow officer who says, okay, that patient goes to the ICU, that patient needs to go to adult medicine, that person needs to go to cardiology. But you need something like that for this, because they're not going to just come in automatically. You need to think about a dedicated resource for identifying and bringing in patients. And then you also need to be able to explain to patients very clearly what this is. Many programs develop a short video to bring right to the bedside in the emergency room or on the inpatient unit to show what this is. But the person who's speaking to the patient needs to have training on how to speak clearly about the program and the benefits for the patient. That change management that Pippa mentioned, that is really our continuous stakeholder engagement. You need to go, we call this in the United States like a dog and pony show. You need to go around and say to everybody, okay, urologist, this is our program. This is what we can do for urology. Okay, cardiologist, this is what we do. Okay, and go around to all the departments of the hospital to explain, and then you got to go back around again. Because if they don't bring in patients, they're going to forget. We want to default to yes, that this is what we do with this hospital. We bring in patients that way. And even if your program can only bring patients home from, 8 a.m. to 10 p.m., it needs to be a 24/7 process. So who in the hospital overnight can hold the patient till 8 a.m. to bring them home the next day? And the bottom three things are a lot of technology. We'd love that if you have a robust electronic record, that you can have a little blue dot next to patients or a green dot next to patients who live in the geography your program is in, who maybe have the health insurance that your program takes if it's not a government payer, so that it's easy for the clinicians not to have to think about those logistics. And then you want to have everything else as automated as possible and data fed back so that you can say, okay, there were 100 COPD patients that came into the hospital over that week, and you only took home 98. Only took home 2. What happened to the other 98? And that you want that data to look at and understand your programs. So we think that these are super important, and you need to start from the beginning, and this is how you will go deep to really get all the patients who might benefit from your program. Once you have that established, you can also think about what else you can do. And so for some programs, that is first thinking about other use cases, more surgery, oncology. We do a lot with transplants, et cetera. All those could be add-on conditions that you might be able to bring into the program. This and the next slide are 2 slides from when I was at Mount Sinai, and we had established our program. We had created this team of doctors and nurses who could go to the home, and we started to think about, okay, they're available 24/7. They can do things. Now we can get oxygen in an hour to someone's home. What else would benefit from that besides patients who are in a hospital? And so when we applied to the government, we thought we were only going to do that. But as soon as we were in it and living it every day, we were like, wow, we can do so many other things. And so we started to think about all the other kind of programs you can add on to that. In the United States, hospital and observation are 2 different things that may not translate in every country. Palliative care unit at home. If someone's really palliative care and not hospice, like where you would take care of someone for 6 months, but they're like 3 days, you need to rapidly titrate some pain medication or alleviate symptoms of nausea or vomiting, and you want to do it quickly, you could have them in this kind of a program. Everyone, I'm sure, has the hospital averse, the patient who says, I know I'm having a heart attack, but I'm not going. I am not going to the hospital. So can these programs try to do the second best thing for them and try to make them comfortable and cared for at home? Then we talked about at night. We added pediatrics onto that. And then the last thing is not substituting for a hospital, but substituting for post-hospital rehab and doing that at home. Different acuity. It's like subacute, but it also can be done with this same platform of providers who were established. And then when I moved over from Mount Sinai to full-time at Medically Home, I realized it's actually a little bit more than just the set of providers. And so I'm going to show the same slide that Pippa showed, which is at scale. You really need to have the providers, which is the medical command center, today you probably need some sort of technology to do this more in real time and remote. And what we have found to have large programs where you're admitting, 200, 300 patients, you really need some sort of technology to, we call it like a pizza tracker, like when Uber, like how to get everyone at the right place at the right time and how to get like the oxygen and the people. That kind of technology you really need if you're going to be really large. You cannot just do this on Excel spreadsheets at that size. And then the service providers. I don't know a single program that has everything in-house. They may have the doctors and nurses in-house. They can probably do the labs in-house, maybe the pharmacy, but then they rarely also have the x-ray and the oxygen and this or that all under their one umbrella. So you have to contract with somebody outside there. And once you have those 4 things, that's when you can go wide and get a lot of other use cases. And at the bottom here are some of the things we do at Medically Home / Dispatch Health, which includes emergency room at home. We're doing chemo. We work with a partner who calls it Cancer Care Beyond Walls. Also, again, that nursing home or rehab substitution, for us, an acronym is SNF, Skilled Nursing Facility Substitution at Home. So that's how we get this larger program of that. So I hope that helped. I was trying to explain both how you can go deep and get all the medical admissions to get to that 15 to 20% of the hospital now at home, and going wide and getting a lot of other things under your same umbrella for hospitalizations. So thank you very much.
Agradecemos a la doctora Linda por su presentación y su experiencia compartida con nosotros.